Right. So welcome everybody. Uh, we welcome you back again to the new edition of the DY Patil Postgraduate Lecture Series. And I'm very happy to invite on our forum today Dr. Nishant Goyal, who will be introduced in detail with his credentials by Dr. Sushil Kavande. But it is my pleasure to invite you, and I'm very happy that you could make the time and be with us today,
Thank you.
Dr. Goyal.
Thank you so much.
Uh, Dr. Gavande is going to be chairing the session today. Welcome, Dr. Gavande, and we are
Thank you, sir.
very pleased to have you with us. Dr. Gavande is a professor of psychiatry at the NKP ISMS College at Nagpur. He is the president of the Psychiatric Society at Nagpur. He was from 21 to 22. He is a chairman of the Arts and Cultural Subcommittee of the IPS West Zone. He's he was the chairman last year as well, and he is again repeated clearly because of his excellent credentials. He's a gold medalist in his postgraduate exams. He has 30 national and 7 international publications to his credit. He has written various books for postgraduate students, for interns on the various domains of psychiatry. He's also published some material in textbooks published by the Balbharti School at Balbharti at Pune. He is on the editorial board of various eminent journals. He is a team member for the IPS guidelines for screen use. And he is not just a good psychiatrist and an excellent clinician and a good academic, but he is also a multifaceted person with interests in drama, in music. He is a well acclaimed flutist. I wish we could invite him to have an encore with us today, but this is an academic forum, so I will have to wait for that privilege on some other occasion. But it's my pleasure and privilege to invite Dr. Gavande for the session today. And I'll request him to take over the proceedings and introduce Dr. Goyal and give a small introduction for the session. I'll come back to you at the end of the program to deliver the vote of thanks. Over to you, Dr.
Yeah.
Gavande.
Thank you. Thank you so much. First of all, thank you so much, Rashmin sir, for giving this opportunity. And all the students and the delegates who joined here, I welcome you all on the behalf of D.Y. Patil Medical College in Navi Mumbai in this D.Y. Patil Postgraduate Students Lecture Series. Friends, neuromodulation or non-invasive brain stimulation is a future of psychiatry, and sooner or later we all going to embrace it. Imagine the situation 5 years back when RTMS was just a matter of talk in the conferences, but now there are so many institutes in India. We are using RTMS very regularly. In fact, in my institute in Nagpur we are using RTMS regularly. So 5 years back the situation was very different, and now the situation is very different. So something new will definitely come to psychiatry, but at this moment of time, non-invasive neuromodulation or brain stimulation is the science which would rule the psychiatry at a large level. Not only psychiatrists, but all the stakeholders, even the patients, their relatives, they are aware about such type of the development. And very often we discuss this in the clinic. Some patient, they themselves ask, what doctor, can we go to some magnetic stimulation and not for electroconvulsive therapy? Such discussion wasn't there a few years back, but now it started in the clinical practice as well. Friends, we are extremely fortunate to have a very appropriate person for today's lecture on these basic sciences of non-invasive neuromodulation. Why I'm saying appropriate person? Because Dr. Nishant Goyal, who is a professor at Central Institute of Psychiatry, Ranchi, is a general secretary and a founder member of Neuromodulation Society of India. So, who will be a better person to talk on this topic than Dr. Nishant Goyal? Dr. Nishant Goyal is in charge of child and adolescent Mental Health at CIP Ranchi, of Functional MRI and Cognitive Neurosciences. Friends, we struggle for one publication, one fellowship, but there are 100 plus publications to the credit of Dr. Nishant. As I said, for the fellowship and awards also we struggle a lot. There are 30 plus awards and fellowships to the credit of Dr. Nishant. He was a editor for Eastern Journal of Psychiatry, and now he is an associate editor for GICAM, that is Journal of Indian Association for Child and Adolescent Mental Health. He being an academician is also an in charge of academic session at CIP Ranchi. So having such a stalwart person with us is opportunity for every one of us to learn something more about the future of psychiatry, which would be definitely ruled by the neuromodulation and the techniques belonging to neuromodulation. So with this very brief introduction, I would request Dr. Nishant to go ahead. Nishant sir, platform is your. You can begin with your lecture. Thank you so much.
Thank you, Dr. Sushil. Thank you so much for your kind words. So just allow me to share my screen so that I can start, like today's proceedings. I hope my screen is visible to all of you.
Absolutely.
Thank
Yes,
you.
yes, it's perfect.
So, uh, uh, thank you for your kind words, Dr. Sushil and Dr. Rashmin. As in this, I think this is a monthly series which DY Patil School of Medicine Department of Psychiatry has for postgraduates. So there are so many logos on on my screen. You can see on the left hand side is the logo of Neuromodulation Society of India. Then and there are other logos I'll be talking about as I go ahead. First of all, I would like to thank Dr. Rashmin and the Department of Psychiatry, School of Medicine at DY Patil University. And most importantly, my team. There are n number of members in my team which works with me in my department. So every resident, every student, all my technicians, everyone. So I'm so thankful to all of them. Because of all of these people, I'm here sharing a little bit of knowledge of mine, which I have gathered over the last 25 years working with neuromodulation with all of you. So just a disclaimer that I also have been an awardee of Clinical Research Center for Neuromodulation in Psychiatry. It's a multi-center initiative to advance interventional psychiatry in India. This is basically funded by Welcome DBT and NIMHANS, CIP, and KMC Manipal. So we are running this project. It is in the final year of its inception. I come from this place. This is called KS Mani Center for Cognitive Neurosciences, CIP Ranchi. And these are some glimpses of the rooms in which various neuromodulation machines are there, which are regularly used at CIP Ranchi. So as I am telling you, we have a dedicated setup for cognitive neuroscience where we have we do clinical EEGs, we do research, high-end EEGs from 64 to 256 channels. We have a full-fledged brain stimulation lab. We have a full-fledged neuroplasticity lab. We have deep TMS. In fact, we were the first in the country to have deep TMS. In India, even before places like NIMHANS. Then we have functional near infrared spectroscopy and autonomic nervous system lab. So on this why I am telling you all these things, because I just wanted to reiterate that we are working on all these things. It's just not that I'm just doing a literature review and sharing the things in front of you. So why neuromodulation? This is very important, that why the need for neuromodulation actually came up. All of you, maybe many of you might have gone through this editorial, which came long back, I think 12 or 13 years back in British Journal of Psychiatry, which are like this question was asked by Dr. PGC that whether psychopharmacology has a future. And I'm sure all of you would agree that number one is very little progress has happened in terms of psychopharmacology. There are very few psychotropic agents which are in the pipeline. uh, and most of the psychotropic agents are actually prescribed outside the realms of psychiatric practice. Like cardiologists, general physicians, they write, a lot of psychiatric medications. But on the other hand, the practice of psychiatry in the 21st century has been, studied with various advances, scientific and technological advances in genomics, proteomics, epigenetics, neuropsychology, neuroimmunology. You can think of it, things are happening in psychiatry. Now, in the last 2, 3 years, a lot of talk has been about robotics, back engineering, artificial intelligence. So, new areas of psychiatric specialization are coming up. Now, people are talking about like things like customized psychiatry, interventional psychiatry, the way you have interventional cardiology or interventional radiology, you have cancer treatment being precise to the particular individual. The same things are now gradually being talked about for psychiatry as well. So on this backdrop, let us dwell into or dive into what is basically neuromodulation. So it is a field of science, medicine, and bioengineering. So there are three parts of it: science, medicine, and bioengineering, which encompasses implantable and non-implantable technologies, electrical or chemical, for the purpose of improving quality of life and functioning of human beings. This is the definition which is given by the International Neuromodulation Society. Now, I always show this visual abstract, which came, I think, 4 years back in BMJ, which actually talked about that how non-invasive or non-surgical brain stimulation has got definitely good, or maybe not better, maybe good, response rates when it is compared to ECT, magnetic seizure therapy, or other things. So you can see on the left hand side, the green ones, that there is significant odds ratio in terms of response rates, and very, very significantly less discontinuation ratio. You can see on the right hand side of the screen when people are giving TMS. So this was a visual abstract encompassing 113 RCTs, encompassing around 6,750 patients with depression. So this is only about depression. So which gives us an idea that NIBS or non-invasive neuromodulation is something which is far from just being to be talked about. So to be very frank, neuromodulation is not about just putting a wire through some of your the body pores and like giving some electricity or some electrical energy. The basic assumption behind neuromodulation is that brain is an electrochemical organ which can be modulated by either pharmacotherapy or certain devices. One device we have been using for years together, now more than 85 years, that is electroconvulsive therapy. So with changing neuroscience research and psychiatric therapies, new tools are gradually coming up, which are basically validating the functional neuroanatomy of our brain. Now, you can see your brain, it is a complex electrochemical network. Agar, if you like just try to tether it out, you can see that there are tracks through which information flow from one part of the brain to other part of the brain. Then there are certain networks on the right hand side, if you can see, and how we are actually modulating things. ECT, definitely you all know that it works at the level of cells, or it works at the level of fibers. Ketamine, a lot of talk has been happening on ketamine. It works on the synapses or synaptic vesicles. And things like RTMS or TDCS, they basically act upon the functional connectivity, as you can see on the left side of the screen. Now, what are the various treatments, or what are the various neuromodulation methods, from least to most invasive? You can see basic among depending upon like how invasive they are. The least invasive being is transcranial direct current stimulation, which we'll be talking about at the last. RTMS, which we'll be talking about just now. ECT, you all know. Now you can say that ECT is invasive or non-invasive. To me, ECT is quasi-invasive because you actually give anesthesia, a seizure is produced, a person actually becomes unconscious while the ECT is being delivered. Then we have implantable devices like vagal nerve stimulation, deep brain stimulation, which are the most invasive methods, which are not under the purview of today's discussion. Then pharmaceuticals, you all know, A lot of work is happening on ketamine. Recently, a lot is happening, like a lot of research is coming up in various journals about using psychedelics, like psilocybin and other things. I'll not go into details of the resolution part because I want to focus on the basics of neuromodulation today. Now, the current state of neuromodulation says that today we have more than a dozen forms of non-invasive neuromodulation techniques either being approved by US FDA or in development for various psychiatric disorders. We have three dedicated PubMed indexed international journals exclusively for brain stimulation. With all this, still, particularly from our country perspective, there is a strong discrepancy between the direction of our field and our current training schema. And that is one of the reasons why we are sitting here today. And we've been doing this. I have been doing this for the last 5 to 7 years, going in various forums talking about neuromodulation. And actually, many people are actually embracing it. And basic knowledge is always good and is always required whenever you start something new. Very quickly, the next 2 or 3 minutes about ECT. We cannot talk about non-invasive neuromodulation without touching upon the advances in ECT. So as we all know, ECT is called the father of brain stimulation, still carries a risk and has a lot of talk about cognitive side effects. To curb or to better down those cognitive side effects, things are happening when it comes to refining the electrical stimulus. Now, by saying that, now you're reducing the pulse width. This is the best way, to people say, to reduce the cognitive side effects. So it all started with brief wave, brief pulse, sorry, sine wave, then brief pulse. Now we have something called ultra brief pulse stimulation. Now this ultra brief pulse stimulation took another dive where they made it unidirectional stimulation, either through anode or through cathode, which is known as feast. Now, what is FEAST? FEAST stands for Focal Electrically Administered Seizure Therapy. So, what happens in FEAST, that we put the anode or the positively charged electrode over, say, right eyebrow, and the cathode is placed on the tangential nasion-enion line. And when stimulus is given, it produces a focal seizure. It does not produce a generalized tonic-clonic seizure or a generalized seizure. So it all started 7 years back, where the group led by Dr. Harold Seckham, they started looking into the safety and efficacy of FEAST, which is, according to them, was a new method of providing electroconvulsive therapy. But again, till now, 7 years elapsed, it has not been approved by US FDA. So then coming over to the true non-invasive brain stimulation techniques. There are three. You can see on your screen, the left-hand side is the transcranial magnetic stimulation, which is the major part of today's discussion in the next 15 or maybe 10 or 15 minutes. Then a little bit about transcranial electrical stimulation. TDCS being the most commonly used and talked about, and then there are other things which we'll be talking about. New methods are coming up, which are called transcranial pulse stimulation or ultrasound stimulation. Again, they are very experimental, so we'll not go into the details of all these things. Now, first coming to TMS. So we say that TMS, is like the holy grail, where we provide a magnetic stimulation, which is focal, non-invasive, non-convulsive, which suppose it stimulates the prefrontal cortex, in which we actually convert the electrical energy first into magnetic energy. Then this magnetic energy, it induces electrical field in the tissues, produces tissue current, they induce charge density and produce the behavioral effect. This is a little bit complicated, so I'll try to simplify what I'm saying. Before saying that, first we have to understand the difference between ECT and TMS. So the basic difference is, one is invasive, one is non-invasive. Seizure and anesthesia is there in ECT but not in TMS. In ECT, the current flows radially, whereas in TMS it flows tangentially. Magnetic devices, the history of magnetic stimulation dates back when Michael Faraday actually talked about the electromagnetic waves. A lot of people started using various type of machine to induce magnetic fields around the body of the human beings. The figure on the left hand side is basically Dr. Philip Barker, who first produced the modern magnetic stimulator, which was approved by US FDA for or to be used on human beings. So this was the first RTMS device which was actually started to be used in 1985. Since then, RTMS and other neuromodulation devices have taken a long way. I'll not dwell much into the history part of it. Coming to what TMS is all about. So TMS basically carries three laws of electromagnetism. One is the Biot-Savart law, one is the Faraday law, and one is the Ohm's law. I'll not go into the details of that. What it does, we first produced a pulsed electric current in a magnetic coil. You can see, over here. So this is how the pulse current is produced. It produces a fluctuating magnetic field. When you put this thing on the scalp, it causes eddy currents in the nearby conductor. The conductor is our brain or our body. So electrical pulses of sufficient strength, short enough duration, which are rapidly changing, they penetrate into the skull and they reach the brain. They induce a secondary ionic current leading to depolarization of neurons. So ultimately, what we require to cause a neurostimulation and neuromodulation is depolarization of neuron. At what place, how deep, how superficial, we'll just see now. So just try to understand from this schematic diagram. So whenever we just provide stimulation, it causes depolarization of, you can see over here, it can cause depolarization neuron on the dorsolateral prefrontal cortex, causing local neurotransmitter release. Now this leads, because of the making of the brain, this local neurotransmitter release, it gets transferred leading to depolarization of the pyramidal neurons of the DLPFC, causing neurotransmitter release in the deeper brain neurons. And this causes activation of deep brain neurons, causing secondary effect on the remaining part of the targeted brain circuit. Now you can see you are providing current over here, but by virtue of the circuitry of the brain, it reaches here and then it causes stimulation of this entire area. All these areas are getting stimulated. And you can see with people when they did fMRI, so they found that by stimulating the DLPFC, it was causing stimulation or activation of the anterior cingulate cortex as well, or maybe on the other side of the brain. So these effects are associated with the improvement in the target symptoms. So whenever we are envisaging response to TMS or RTMS, there are certain attributes, there are certain mechanical attributes, there are certain clinical attributes which are important. So whenever you are giving RTMS, all these things are very, very important. Where you are giving RTMS, the site of stimulation, how strong is the stimulation, how you are putting the coil, what are the various illness related variables, severity of illness, dysfunction associated with illness, duration of illness, so on and so forth. What are the various types of coil you are using and how frequently you are using that stimulation. So all of you or all of us have to remember these lingos associated with RTMS. First, coming to the depth, how deep the current is or the magnetic current has to go down. So it all started with development of circular coil leading to development of double cone coil. Now, in the last 5 years, we are in a very, very exciting era of using H coils or helmet coils or Hesset coils. So as these coils are being evolved, they are penetrating deeper into the brain. The most commonly used RTMS coil is the figure of 8 coil. You can see it over here. Then the shape of the coil. If you can see over here, we always yearn for focally stimulating a part of the brain. Now, they say that when we use a figure of 8 coil or like a butterfly coil, the maximum area of stimulation is in the middle. or we are using a circular coil, it is producing a more wide range stimulation. So the field or the magnetic or electromagnetic field which is underneath the figure of eight coil is more focal. So that is why figure of eight coil is used more commonly rather than the double cone, rather than the circular coil. You can see it over here as well. As I said, how deep it goes. By convention, they say that a figure of eight coil can go maximum up to 2.5 millimeter, at times up to 1 centimeter, around 1.5 to 1.6 centimeters. It cannot go to medial areas or subcortical areas by virtue of how it is producing the electrical current. Then the spread of activation. Our brain is very widely and vastly connected to each other. So whenever you are stimulating one part or the one focus of the brain, it is both spreading within the hemisphere or between the hemispheres. You can see it from here. And by virtue of the connectivity of the brain, TMS actually takes the advantage of the natural brain circuitry. As I was telling you, DLPFC or the dorsolateral prefrontal cortex is the lateral aspect of a middle frontal gyrus. It is very widely interconnected with the limbic system that plays a role in the mood modulation or depression. So if you are targeting or if you are stimulating the DLPFC, it actually causing effect on the uh, say the limbic areas or the anterior cingulate cortex by virtue of TMS. Now you can ask me how we measure that actually TMS is producing the effect. What I showed you was network alteration or functional connectivity in one of the slides previously. So measuring the changes using MRI or fMRI or DTI or MRS is one way of looking into it. We also can see the changes in the neural oscillations as measured by EEGs. We measure a lot of neurotransmitters, BDNF, hormones, etc., etc., cerebral blood flow, synaptic plasticity using long-term potentiation and long-term depression, which can also be measured using the same TMS device. So like what I mean to say is stimulation is focal, but the action is not local or focal. It is widespread. Now coming to the lingo of RTMS. So there is something called a pulse or a click. I'm sure you must have heard the click. Now, if you have multiple clicks, this is maybe for a second, it is called as 5 hertz. So 5 clicks over a period of 1 second is known as 5 hertz. Then if you have 2 sets of 5 clicks between 20 seconds, this is known as a train. So a click, a pulse, and a train. And then the distance between the two trains is known as the intertrain interval. We need to know these basics because when we talk about low frequency, high frequency, theta, and all those things, it becomes easier for us to understand. So this is how a conventional RTMS train and click looks like. So any frequency of 1 hertz or less is known as low frequency RTMS. Any frequency which is more than 5 hertz is known as high frequency RTMS. So any frequency, right? Then the other part is called the pattern TMS. I'll be talking about it. So something is known as intermittent theta burst stimulation, or which is akin to high frequency RTMS. Another is continuous theta burst stimulation, which is akin to low frequency RTMS. By virtue of stimulation, high frequency RTMS or intermittent theta burst stimulation, they stimulate the brain or they activate the brain. And the otherwise low frequency or continuous theta burst stimulation, they inhibit the brain. So the part of the brain which you are stimulating, which requires either activation or depression, is depending upon what type of stimulation you are using. I'll come to it, right? So suppose we use high frequency stimulation in burst or train, which is interrupted by pauses. You can see over here, these are the pauses. This is called the intertrain interval. The reason for giving these pauses is to prevent seizure induction. So this is the real, machine which we use at our center, the user interface of it. You can see how it looks like. So suppose I have to give 10 hertz RTMS over the dorsolateral prefrontal cortex, and I decide that in a day I'm going to give 3000 pulses. So I am giving 10 hertz RTMS for 4 seconds. So this is 4 seconds, 10 hertz. So it becomes 40 pulses. Then I wait for 11 seconds. Then again another train of 10 hertz RTMS giving 40 pulses. So to deliver 3000 pulses in one session, I have to give 75 trains. So this 75 trains, giving 75 trains takes around 18 minutes. You can see it over here. So this is how we calculate the overall time which it takes for providing a particular type of stimulation. Once in, it might sound a bit, confusing for you, but once you are into it, it is very, very easy, very, very simple, very, very easy. Then the same thing goes for theta burst stimulation. Again, I'll talk only about the theta burst stimulation. As I told you that when we were giving high frequency, low frequency RTMS, it was taking a lot of time. So people with good advancements, they thought that shorter sessions, they might produce more robust plasticity as compared to the conventional RTMS. So what they started to give small pockets or burst of 50 hertz RTMS at 5 hertz. So theta is 5, right? So you can see these lines. So every line is basically 50 hertz stimulation. So whenever we are giving continuously, it causes inhibition of the cortex. That is called CTBS, or continuous theta burst stimulation. And when we are giving it intermittently, it causes excitation of the cortex. So just to summarize it over here, this is how conventional RTMS looks like, and this is how patterned RTMS looks like. So again, this is the user interface of patterned RTMS. You can see now in patterned RTMS, we give less number of pulses. So the type of work those 3000 high frequency stimulation was giving, we can do it in 600 pulses. And we will only take 3 minutes, 9 seconds, apart from that 18 minutes for giving intermittent theta burst stimulation. You can see, again, this is a very simple calculation. The machine can do all the calculation. You just have to decide at what power I have to get RTMS, what is the area of the brain or the region we have to give RTMS, which type of RTMS, and for what indication. Everything else will be done by the machine. So in clinical setting, this is how it looks like. Suppose in a case of depression, I have to give high frequency RTMS, 3000 pulses in a day. So this is how it looks like. So if I use 10 hertz frequency, I have to give around 10 trains of around 50 pulses per train, and I will take around 30 minutes time. Suppose I'm using low frequency RTMS over the temporoparietal cortex to actually inhibit the brain where people are having auditory hallucinations. So suppose I have to give 1200 pulses per train, it'll take around 20 minutes. The same case, if I have to give intermittent theta burst stimulation for around 600 to 900 pulses, it will only take 4 to 7 minutes. And same for CTBS. The areas which we stimulate, the most common area stimulated is the DLPFC, or the dorsolateral prefrontal cortex. We use supplementary motor area. I'll show you in the subsequent slide where they are actually located. SFG, temporoparietal junction, motor cortex, occipital cortex, cerebellum. Now, where to locate all these things? It's very, very simple way. If you know the 1020 electrode positioning system of EEG, you can very well locate all these areas. So I'll show you one by one. Motor cortex. Motor cortex is basically stimulated when we are using RTMS for movement disorders like Parky and other things. So you stimulate at C3, or the left motor area. Left motor area correspond to the C3 area, which is the midway between T3 and CZ. Then the DLPFC. DLPFC correspond to the F3. I'm saying left side, you can take right hand side also, but left side which we usually stimulate. Then the temporoparietal cortex, it is basically the midpoint between T3 and P3. See, this is T5. So this is the one corresponding to the temporoparietal cortex. SMA for OCD. Again, this is a very simple way to look into it. It is just 1 centimeter ahead of the vertex. You can, sorry, 3 centimeter ahead of the vertex. You can see it over here. Some people, they stimulate the orbitofrontal cortex for OCD. So the OFC is basically the midpoint between FP1 and F7. It's called the AF7. Of late, people are stimulating cerebellum also. They say that the cerebellar circuit or the CSTC circuit is actually affected in various psychiatric disorders. So they're using it cerebellum. We basically stimulate the enion. So how to identify the area? There are 101 ways of identifying the areas. It all started with crude method of 5 centimeter. I'll not tell you in detail right now because I have to tell other things also. But as I told you, the EEG point of F3 corresponds to the DLPFC. There are other methods called the beam method, and one is called the MRI-based neuronavigation, which I'll tell very quickly at the end. Then with advancements from conventional RTMS to theta burst stimulation, now the last 2 years, we have something called accelerated TMS. People were looking for, some activity, some method where we can treat like actively suicidal patients. Or when we are giving, stimulations for 2 weeks, 3 weeks, can we do it in a week or maybe less than a week? So they coined something called accelerated TMS, in which we can both use RTMS and or theta burst stimulation, basically to get equal or greater effects by giving repeated stimulations within a short interval of time. How it came with a protocol which was basically US FDA approved in 2022, developed by Cole et al. They said that if you give 5 consecutive days of 10 ITBS sessions per day, that is around 18,000 pulses per day, which would be over in almost 4 to 6 hours. They say that it will lead to significant improvement in depression within 5 days. So they did it on 21 cases of major depression, out of which 19 patients achieved remission within a week. And there was a lot of talk about this SAINT protocol. And we also tried at CIP and NIMHANS, but because of significant side effect, we could not, take it further. So we aborted it in the middle. There are other ways of giving accelerated stimulation, like if you want to give it for maybe, usually it all started with 10 sessions over a period of 2 weeks. But if you want to give 15 sessions or 21 sessions, that is also fine. This is one we actually did and we published in OCD. Now, just to show you the machines which we are using at CIP for RTMS, this is a conventional maximum machine which we are using at our institute. It all started with this machine, then we graduated to this one. Now we have something called a robot. This is the real picture of the robot on the right hand side, you can see at CIP. So what robot does is how you hold the RTMS coil either with your hand or on a stand. Using a robot gives you a lot of precision. Suppose a person is moving his head, the robot will automatically correct that movement so that maximum stimulation goes where it is supposed to be sent. Then we have other systems. We have a TMS EEG. We have something called quadruple stimulators. This is how stimulation is being given in our lab. This is the neuronavigation. Again, I'll not go into details of neuronavigation. Then the most recent advances or advancement in RTMS is called the deep TMS. You have to remember, deep TMS is not synonymous with DBS. DBS is an invasive method used by neurosurgeons. They open the brain and they implant a device within the brain. Deep TMS is basically changing the orientation of coil in such a way that you make or to convert the coil in the shape of a helmet. Now, doing that, 3 type of coils were developed by a company from Israel called Brainsway, which were named as the H1 coil, the H7 coil, and the H4 coil. And interestingly, in the last 2-3 years, they got US FDA approval using H1 coil for treatment of depression, H7 coil for treatment of OCD, and H4 coil for smoking sedation. A lot of work is happening. As I told you, this is a typical H7 coil. So it is just like a helmet. You can see. So it just fits into the brain, sorry, on the scalp of the individual, and it is connected to a stimulator. You can see it over here, and you can give low frequency, high frequency, theta burst, all type of stimulation, the same way you are using with a figure of 8 or a double cone coil. So we started publishing this as well. Now, as things went ahead, people thought that there are other ways or other innovation in using RTMS. I'll come to that at the last. Now, coming very quickly, coming to the evidence for TMS. What the evidence do we have for TMS? IPS or Indian Psychiatric Society, CPG, they published a recommendation which says that there are definite indications of evidences for its use in depression, all type of depressions. Generalized anxiety disorder, OCD, PTSD, negative symptoms of schizophrenia and auditory hallucination schizophrenia, smoking cessation, Alzheimer's, insomnia, migraine, fibromyalgia, tinnitus. Other things you can see on the right hand side of the screen, there is some anecdotal evidence, but not approved evidences for that. Very quickly taking you through how you do it. So for depression, like unipolar or bipolar or resistant depression, you give high frequency RTMS or the deep TMS to the left DLPFC. Now, what I mean to say is that the left side of the brain or the active side of the brain is, the DLPFC is less functioning or it is hypofunctioning. So you have to activate or stimulate the DLPFC. So you use a high frequency DLPFC. The same can be seen for organic depression as well. For GAD, OCD, PTSD, anxiety spectrum and OC spectrum disorders, there are a lot of variations. People have said that giving inhibitory RTMS over the right DLPFC, or you can use inhibitory RTMS over the supplementary motor area. But supplementary motor area is not there in the practice guidelines because not much evidence is there. But a lot of work has happened over there. In schizophrenia, there are two symptom clusters. One is the resistant auditory hallucination and the negative symptoms. Negative symptoms is like depression, high frequency, or the excitatory RTMS over the left DLPFC. For resistant auditory hallucination, low frequency to the left temporoparietal cortex. Now, what I mean to say is, if you want to use theta burst stimulation, you have to just convert high frequency to intermittent theta burst and low frequency to continuous theta burst. The same effect you can see. For substance use disorder, high frequency to the left DLPFC. For Alzheimer's, the same. You don't treat Alzheimer's dementia for improvement in cognition. No. Primarily, RTMS is recommended for improving behavioral and psychological symptoms of dementia. Some people have used it for improving cognition, but you don't have robust findings for that. Then again, for insomnia, headache, tinnitus, different things have been tried by different individuals. This is the table of indication. I'll not, you can have it later on. So in fact, I would suggest somebody is using RTMS, they can put this, they can print it and they can put on the wall of the place where they are giving RTMS, which it will help you take decision upon for what condition you want to use which type of RTMS. Same thing in a different manner. Deep TMS, I've already told you, H1 coil is for depression, H7 coil is for OCD, and H4 coil is for smoking cessation. Now, quickly, in the next maybe 5 or 10 minutes, the next part of my presentation, or maybe the last part of my presentation, is the direct current stimulation, or the transcranial electrical stimulation. Now, as compared to RTMS, TDCS is relatively cheaper, easier, portable, and it has got less adverse effects. Now, the history of TDCS or transcranial electric stimulation before the history of RTMS. Like, in the time of Hippocrates and Galen, people used to use torpedo fish to, treat headaches, gout, and other things. Neuromodulation platforms where electrical energy is delivered to the target can be divided into three. Implants, we all use for DBS, as I was telling you. In hospital stimulation, I was talking about TMS and electroconvulsive therapy. The wearable devices are transcranial electrical stimulation, which primarily has TDCS. Why I'm saying it wearable, I'll tell you at the end when I'll be finishing with TDCS. So all form of electrical current application to the brain non-invasively using an electrode to the head is called as TES, or transcranial electrical stimulation. It can be divided into three basic things. One is the TDCS, one is the high definition TDCS, HD TDCS, and then there are newer methods called transcranial random noise stimulation and transcranial alternating current stimulation. So these are the various devices which have been developed over a period of time since 1990s. You would be astonished to know that even TMS or TDCS systems are available on Amazon for treatment of headache or migraine, which comes for 30,000, 35,000 rupees. So in nutshell, what is a TDCS device? It is a wearable brain stimulator which applies direct current, and it is probably the most investigated interventional neurotechnology. It's very, very simple. You have a positively charged cathode and a negatively charged cathode. They say that the current travels from positively charged cathode to negatively charged cathode or anode. And this is how it produces changes in the part of the brain. You can see it over here. So the negatively charged electrode is the cathode and the positively charged electrode is the anode. And the current travels from positively to negatively charged anode and cathode, and in between, how as the current is basically traveling from one part of the other, it is stimulating the area of the brain which is beneath that travel. So we give 2 milliampere currents for around 20 to 30 minutes. This is the conventional TDCS which has been given. Depending upon, again, the same thing for RTMS, the area of the brain which has to be stimulated or inhibited. Suppose you want to stimulate the area, you put it beneath the anode. If you want to inhibit the area, you place it beneath the cathode. I'll tell you how it happens or how it does. So depending on the size, position, and the current, we have different positions for various electrodes. As I told you, the current passes between anode to cathode. The direct current, the current is inward under anode and outward toward cathode. How does it look like? I'll tell you. See, suppose the electrode is placed on the head surface. You can see this head surface. You can see this over here. This is a cortical neuron, and the current flows from anode down. So it causes depolarization of the cell and hyperpolarization of the compartments. It causes increased excitability or plasticity of the area which it is stimulating. The other way around, the cathode. Now the cathode is this, the black one. Now from cathode, the current is flowing out, during which what it causes depolarization of the compartments which are near the skull and hyperpolarization of the cell. It decreases the cortical plasticity or the cortical excitability. On this principle, TDCS and HD TDCS works. So the central assumption is that the inward causes excitation and outward flow causes inhibition. So what we do is we place the active electrode over the target, which we have to excite. And the other electrode we can put anywhere which we want to inhibit. So it can be a reference electrode, it can be a cathode, anything of that sort. What is HD TDCS? In typical TDCS, we are basically using only one channel with two electrodes. In HD TDCS, we use an array of electrodes. You can see it over here, an array of electrodes. Over here, we were just having two. Over here, we have one anode and four cathodes or four surrounding cathodes. You can see this is the anode and these are the four surrounding cathodes. So what is happening? We are putting 2 milliampere current in the brain through this anode, and through these four cathode, 0.5 milliampere each, the current is coming out. So by changing the polarity, what it does, this ring in arrangement, the the overall focus of the stimulation becomes more, and it penetrates deeper into the brain. So this is how HDTDCS works. So these are the recommendations, the same recommendations which are given in IPS CPG guidelines. It has been, suppose I'll give you one example. For depression, we use left DLPFC anodal stimulation or right DLPFC cathodal stimulation for say around 30 minutes, one day or twice, per day for 5 to 10 days. So these are various permutation and combination where TDCS has been used and recommended. Now it is the last part of it is more of investigational, or I would say like more of research part of it, something called hybrid stimulation. In hybrid stimulation, what we do, for example, we combine TDCS with TMS or theta bus stimulation, or we combine alternating current stimulation with theta bus stimulation. So we have also been publishing a lot around these things. The other experimental methods are deep brain stimulation. I already told you. Then alternating current stimulation. A lot of work is happening in CIP over TACS. Then random noise stimulation, laser stimulation, external trigeminal nerve stimulation. People have been trying over a period of time. Now, in the next 2-3 minutes, I'll finish. I hope I'm not taking too much of time. What the future beholds. Now, the future stand is there for tele-TECS. I was telling you that it is called as the wearable device. Now, what is the beauty of having a wearable device is that the person can take this device at home, and the clinician can actually manage this device while sitting in his clinics through either Bluetooth or internet, and the person doesn't need to come again and again for the stimulation. As I told you, need to give stimulation for the 2 to 3 weeks. So the person can keep this device. It's a very small device. It's just like, your mobile phone. So you can keep it. They have to just, wear that band or that cap in which the electrodes are already embedded. The person remotely, just they switch on and they can switch on and switch off the device. So during COVID times, it was found that using tele-TECS was portable, easy to administer, safe, non-invasive. It was found to be cheaper. They found that it was much cheaper than calling the patient again and again every day. It was cheaper. It was suited for long-term use. And they thought that it might be used for neurorehabilitation in old age psychiatry or maybe old age neurology. Then ethics. It is very, very important whenever you are exercising neuromodulation, though they say the risk is small, but risk is always there. So whenever you are planning RTMS, TDCS, deep TMS, whatever you are doing it, you have to keep on thinking how you can minimize the discomfort and the risks to the client. What is the minimum required stimulation? Does the information is clear and you have taken the consent? Our people are screened, you are properly trained, and all emergency procedures are there in place. I'll not go into the details of this. If somebody has some questions around it, I'm more than happy to answer later on as well. The safety is all about the heating beneath the scalp, the magnetic field exposure, which is very, very minimal. People have hearing issues, some mental implants issues, seizure issues there. But again, seizure is the most serious side effect. But again, in my personal experience of using RTMS for 22 years, I have only one case of seizure. NIMHANS, they have not more than 5 cases of seizures. Common side effects are tenderness of the scalp, facial twitching, neck pain, acute mood changes, or maximum burning of the scalp, which actually lasts for the day, then it goes off. Now, something called precision neuromodulation, which is what we have in CIP, and I think CIP has the first and the only precision neuromodulation lab, not only in India, but in the entire Southeast Asia. So again, I'll not go into the details of what we what we do it over here. So what does precision neuromodulation means is we basically take the person specific head model. You can see it over here by putting a person in this, this is called the GPS system. Then we create a head model of the individual. Then we take the MRI of this individual and we superimpose these two models and we produce the most specific electrode position for that particular individual, which we can use for providing electrical stimulation as well as for giving for doing EEGs as well. So this is something which we have started to do for the last 1 year. I think 2 projects at CIP are going on this. And this is, they say that this is the most precise way of locating the part of the brain by which we can not only maximize the effect, as well as we can minimize the risk of neuromodulation. Again, I'll not go into details of this. So I'll conclude by saying that people have been proposing a new subspecialty of psychiatry called the interventional psychiatry, where it has all these things. We need to formally recognize and develop operationalized training programs in these particular things. Today's talk is just one small step towards that. Definitely, it will provide us more, options to better meet the challenges of treatment-resistant psychiatric disorders while using a safe and ethical practice or more informed development. Definitely, integrated novel neuromodulation techniques have a long way to go. Thank you very much for your patient listening and kind attention. I'll end sharing my slides over here, and I'm putting it back to the moderator. Thank you all for listening. Over to you, sir.
Thank you, Nishant. Thank you so much. Uh, it was really touching to the basics of RTMS, uh, TDCS, and all the neuromodulations. We have started with the ECT, and slowly we moved towards RTMS and all the newer modalities. And I think students in CIP must be very, very fortunate to have such type of the equipments and the facilities over there. Because as I said in the beginning, this is something like a future of psychiatry. Dr. Nishant, there are few questions. One person he has put this question: how does deep RTMS compared with RTMS, deep TMS compared with RTMS? I think he means to say effectivity wise, how deep TMS is effective as compared to RTMS.
Right, sir. So there are two ways of looking into it. The one is the theoretical way. Now, deep TMS, by virtue of the way it stimulates the cortex, the stimulation reaches up to 2.5 to 2.7 centimeters beneath the skull. The conventional RTMS, the stimulation reaches maximum up to 1.3 to 1.4 centimeters beneath the skull. So we presume that it is stimulating deeper or the deeper structures. One. So we presume that it will lead to better benefit than RTMS. So this is one part of it. The other part of it is by providing the clinical evidence. Now, to provide clinical evidence, we have to do comparative studies between deep TMS and RTMS. So people have started to do these type of studies, and definitely, some great things might come up. Now, there are different ways of looking into it. People are comparing deep TMS stimulation with theta burst stimulation, deep TMS stimulation with RTMS. But definitely, having a deep TMS facility gives you an edge, because you can do normal RTMS also, conventional RTMS also with that. At the same time, you can do deep TMS with that. But again, you cannot compare apple with mangoes or apple with oranges, right? So the methods are completely different.
Different, yes,
This is
yes,
how it
yes.
is.
One person he wants to know with the emergence of TDCS gadgets all around, is there any regulatory body which can monitor the ethical issues related with the TDCS machines?
Yes, I think it's a very, very important question to ask. Over a period of time, people have started to understand, particularly electrical stimulation. Anyone can make an electrical stimulation. It is just like a battery. So any double A battery or a 4A battery which has an anode and a cathode, anyone can create that. In our childhood, we used to make those torches and electrical torches, right? So stimulate, that is just like that. So he's asking that DIY, the do it yourself gadgets, they were coming up. They are still available in the market. But when you don't have gadgets which are not properly tested, first of all for safety, then for efficacy. So any new gadget which has to be developed, it has to be first tested for safety, then efficacy. So if you don't have, people burn their skull. By DIY gadgets, they actually burn their skull. So there are regulatory bodies. Now it has been included under the DCGI wing is there, Drug and the Machine Controller Journal of India. So they have some gadget notification around, medical device. They come under medical devices. So we have certain regulations where you have to have some basic standards of having these medical devices. So either they are CE certified or they are FDA certified. Still in India, we don't have certification facility available, but we extrapolate CE certification and FDA certification for using these gadgets.
Absolutely. And to add into that, we have a specialty also in Indian Psychiatric Society. They are working in this area, and we are getting guidelines also. One more person he wants to know, can some patient opt for RTMS without opting for antidepressants and anxiolytics directly?
So again, this is it's a very hypothetical question.
Yes.
Whatever data we have and whatever we have been doing, neuromodulation we are doing, it is adjunct to medications. So
Yes.
presuming that it will replace medicines is a long and far-fetched idea. But yes, the other part of the coin is that if a person comes in to you and they say that I want to try neuromodulation only, so if you have evidence to say that neuromodulation does work in that particular condition, you can give it a try, taking proper consent from that particular individual. But if you ask me today, I will not suggest anyone to take standalone neuromodulation, be it RTMS, TDCS, or any other thing.
Absolutely. One more question. I think he's got inspired with the RTMS so much. So, sir, can deep TMS replace DBS in future?
Sir, I was telling you, DBS is
Yes,
a surgical technique.
all together are different.
It's a surgical technique. Deep TMS is a non-invasive technique. So again, you're asking me to compare apple with oranges,
Match
which
with the
is
man.
theoretically not wise for me to answer. So I'll refrain from asking, responding to this question, sir.
Yes, yes. The last question I would like to add, what is your experience in dealing with the patients having tinnitus, RTMS for tinnitus?
Sir, it's a very interesting question. Frankly speaking, I do not have any evidence or experience because I am work in a tertiary care center where we don't get patients with tinnitus. But my friends across the country and the scientific literature which is available, they say that tinnitus, particularly resistant tinnitus, improves very well with high frequency RTMS. A lot of literature is available, sir. A lot of randomized control trials are there, meta-analysis are there, which say that it's a very, very effective treatment for treatment of recalcitrant tinnitus. So it's something which is worth trying. Though I have not used it, I've just used it on one or two people, and they're more like anecdotal. But literature is available there, so definitely literature is there.
I'm taking the last question from participant, a very interesting question. Uh, she wants to know how long the effect will last, and can we give the maintenance RTMS?
Again, now as we have been using TMS, we are gradually seeing that the acute effects of TMS, they stay for almost 6 to 8 weeks, right? So
Hmm.
to maintain those effects which people have, we propose people to have maintenance treatment. The way we have maintenance ECT and we have prophylactic medications. So overall, of late, people have started to use maintenance treatment. We don't have, at least to my knowledge, we don't have controlled studies which have seen maintenance treatment, but lot of anecdotal reports are there which say that using maintenance treatment definitely improves the quality of life of the individual, as well as the time to relapse increases significantly if you plan and give maintenance treatments.
Yes, yes. And again, a very difficult question for anyone to answer. Someone wants to know the effect of RTMS in glaucoma.
Sir, I'm sorry, I don't have any knowledge about it, sir, to be very frank.
Yes, 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 yes. All those, most of the participants are our students, Dr. Rashmin sir students and my students.
Okay.
So, my dear students, if we go through the literature, you will find the indication right from the tremors to glaucoma, Parkinsonism to multiple sclerosis. but again it depends upon the evidences. Means a person can try, and the case reports are not sufficient enough to build
Yeah.
the proper guidelines. So that would be a consolidated answer to your questions. Thank you, Dr. Nishant. I don't know how to thank you, because it was touching a very, very basic of neuromodulation, and at the same time, we got the broader view of the future of neuromodulation. And we are really, really fortunate to have a speaker
Yeah.
like you. And our students are also really fortunate to have you. And we would definitely like to come personally to CIP to see your laboratory, and we
Most
will
welcome,
come
sir.
with our students. So
Most
we
welcome, sir.
always wait for ANSIPs to happen in CIP,
Sir, don't
because the
wait for
purpose is
answers.
that.
You just come like this, sir. We are
Yes, yes.
like we are not into. We did answers in 2018 when CIP
Yes,
turned
yes,
100 years old. So at
yes,
least
yes,
I have done my lifetime of my life. Like my experience that I will not never have. At least in my hand, I'm not going to have. You are
yes,
most
yes,
welcome
yes, yes,
anytime, sir. Please do come
yes,
visit
yes,
us.
yes, yes,
We offer
yes,
hands-on training for 3 to 5 days.
yes,
People they do come to our lab and seek
yes,
training
yes,
into all these things.
yes.
So you're most
Thank
welcome for
you.
that anytime, sir. Thank you.
Thank you. Thank you. Thank you so much. Thank you
Thank you,
so
Dr.
much,
Sir.
Dr. Nishan. And I now hand over the platform to Dr. Rashmin, sir. Rashmin, sir.
Maybe he's busy with something
Maybe
else.
he's
Yeah.
yeah, he's there. He's there in the
Yeah. He
list.
is there, but maybe he's busy.
Maybe. So
Yeah.
I think being a moderator, I will only conclude this session.
Sure, sir.
So first of all, thank you so much, Dr. Nishan, for such a wonderful session.
Thank you.
And we would definitely like to see your laboratory personally. But you have given us a broad view, bird's eye view of the neuromodulation lab at CIP Rachi. On the behalf of all the students, Nishant, to be very specific, most of the participants were students.
Yes, I
And
know, sir. I know. I was told
yes,
by
yes,
Dr.
yes,
Ashwin that most of them are
yes, yes,
students.
the future generation of psychiatry. So, and
Sure.
they all are very interested in these newer modalities. So, on the behalf of all of them, thank you so much for giving your valuable time and making the topic so simple to understand.
Thank you, sir.
And thank you so much.
Thank you, sir. Thank you for having me.
Yeah,
Have a great day. Good night. Thank you so much.
good night. Yeah,
Bye
thank
bye.
you. Good night. Bye bye.